I'd like to tell you that some of the data I'm providing to you was given to me as a participant of the International Pediatric Stroke Study group. That's a group composed of over 200 people now in representing 80 countries internationally. If any of you are interested in joining this group, just let me know and I can send your information on to Gabrielle de Weber, who organizes this consortium. So I will be giving you data that we compiled and updated as of February 2011. So it's quite recent data. So the way I've structured the talk is to basically go through some definitions because I think it can be a bit confusing, and then we can focus based on the definitions, incidence, etiology, and such. I'll give you some case presentations. We'll talk about management versus treatment, which is very shallow. We'll talk about risk factors, outcomes, and if we have time, potential therapies, but I'll probably save that piece for tomorrow. Let me just check the time. Okay, so what's that? Time's not important? Well, that's for you, but everybody else may have a different idea of it.
Is that the Italian flag?
Yeah. I'm trying to be patriotic to my grandparents.
Donna is Italian originally.
That's right.
She's Donna Maria.
That's right. So basically what we're going to focus on for today's talk is neonatal stroke, which encompasses anything during the in utero period up through the first 28 days of life. We usually reserve the term perinatal stroke to talk about stroke that occurs at or near the time of birth. So, stroke subtypes. In children, they're primarily, we can think of, and in adults, ischemic versus hemorrhagic. For children, that is out of the neonatal period, it's pretty much half and half. Adults, much more ischemic stroke than hemorrhagic stroke. But what about the neonates? They actually have incidents that look much more like that. So when you diagnose a stroke in the nursery, it's much more likely to be ischemic, whether it's caused by an arterial circuit problem or a venous thrombosis. And this is data from International Pediatric Stroke Study. This is over 2,500 children collected over the past almost 10 years now. So in blue, this is arterial ischemic stroke, makes up 71% of all. This is now all children, neonates and older children. Some children have both. About 16% with sinovenous, and this we'll call hemorrhagic. You can see here clearly that the at-risk period is definitely neonatal. That's when most of the strokes are occurring throughout childhood. And if we look at gender for this ischemic stroke, we see that there's a slight male predominance for neonates as well as children. Sinovenous thrombosis is a big issue, and greater than 50% of all childhood sinovenous thrombosis occurs during the neonatal period. It's often associated with ECMO, congenital heart disease, thrombophilias, choreo. And most of these babies have multiple risk factors, and we'll talk about that in a few minutes. But I would say here, this is key. When you have an intraventricular hemorrhage in a term baby, you must exclude venous thrombosis. Because when you do that head ultrasound, you see blood in the center of the brain. But if you more clearly look, you'll see that it's often associated with thalamic hemorrhage. And in this situation here, we see complete thrombosis of the entire sinus system. For sinovenous thrombosis, when we look at the IPSS study, there were almost 500 babies, much higher incidence of males for venous thrombosis, and again, the neonatal period being the period at most risk. We also see venous infarction in infants born at term. Now, these are the babies who leave the nursery, so may escape the attention of most of you here since you spend most of your time in the nursery. But if you do neonatal follow-up, you might end up seeing a baby later with some abnormalities on examination. These babies, when you scan them, have lesions that look like periventricular leukomalacia, but it's not. This is actually the sign of a stroke, most commonly caused by a venous infarct at or near the time of birth, and it could be in the preterm. And here we see, just like I showed you during the previous talk, the effects of this lesion are widespread, and this is the Wallerian degeneration we see in the cerebral peduncle, and this baby will definitely have a hemiparesis. Perinatal hemorrhagic stroke is quite unusual, and when Jennifer Armstrong Wells did this study, she looked at a Kaiser database, and there were many, many births, and she found an incidence of 6 per 100,000, so very rare. 20 cases versus she found 93 cases of arterial ischemic stroke. 19 of these hemorrhagic strokes were intracerebral, and only one was subarachnoid. And I think the subarachnoid hemorrhage is quite common in a normal term baby, and we don't usually view that as a pathological condition and wouldn't come under this diagnostic code. The babies who have hemorrhagic stroke are often encephalopathic. Many of them have seizures, and most of them, we can't find a reason for it. And only one baby actually had a cavernous malformation, accounting for the bleeding, a structural lesion. When these babies are imaged, most of them have unifocal, unilateral lesions that are either left or right-sided, and they occur with more frequency in the parietal lesions, some in the frontal, and some temporal. When she looked at risk factors for this condition, she found that babies who had a history and examination consistent with fetal distress had an odds ratio of over 11. The confidence intervals in these situations are quite broad because there are very few babies. Post-maturity was often associated as well with a very high odds ratio, and this is a modifiable risk factor. And I know in some hospitals in the north of Italy, C-section rates are quite high for this reason. Linda DeVries and her group, Manon Benders, had a lovely paper in the journal Stroke a number of years ago describing what preterm perinatal arterial stroke looked like. They had an incidence of 7 in 1,000 live births with a gestational age ranging from 27 to term. Again, these lesions were more common on the left side, like ischemic stroke is. But instead of it being cortical in location, the location was much more commonly lenticulostriate. The risk factors they found were twin-twin transfusion, abnormal fetal heart rate patterns, and hypoglycemia that alerted them to these conditions. And this is what the MRI looks like. So here we have an infarct in the distribution of the internal capsule. These are the thalami. This is caudate putamen. So it's hitting the internal capsule. And as Eugenio said, these babies are much more likely, because of this cystic lesion, to exhibit a motor impairment at birth. And here's a baby with a thalamic lesion. So what about the babies who have stroke? How do they appear to us? So we usually pick up strokes in the nursery, but many, many more than that come to us with presumed perinatal stroke because they appear much later. And I'd like to go over some of the clinical symptoms associated with these different presentations. So for the acute clinical presentation, seizures usually occur. They're almost always focal unilateral. Often the baby appears well, but I'm going to show you some data from the IPSS that suggests otherwise. And these lesions can be either arterial or venous in nature. And we found when we collected our babies for our MRI studies who had neonatal encephalopathy, about 5% of them actually had stroke rather than classic HIE. This is what the scan will look at, a nice bland infarct here, and the baby presenting with seizures, apnea, hypotonia, and lethargy. This was a 1-day-old, 40 weeks gestation, good APGAR scores, so again, a baby who ends up going to the well baby nursery and then you get called because the baby's having focal motor seizures. And this baby's seizures developed at 8 hours of life, treated very easily with phenobarbital, resolved. I just wanted to show these scans because strokes can be bilateral as well, and in these situations, the babies are much more likely to be affected clinically later. What about delayed presentation? These are the children who present with early handedness, so many of the neonatologists don't have the advantage of seeing how these children present. Some of them will have seizures that bring them to medical attention, but not in the nursery, but later on during infancy. And then the hemiparesis and hand dystonia are picked up. This is now called presumed perinatal ischemic stroke because we don't have absolute confirmation except for an MRI where we see an old lesion. So we say it's presumed perinatal ischemic stroke, PPIS. So here's a patient of mine who's now 11 years old. I think it's pretty easy to see that this baby is doing nothing with his left hand and not much with his left leg as well, although he's appearing quite alert, but he also had a gaze abnormality and a neglect. This baby went on to develop infantile spasms a few months later, very difficult seizures to control. We ended up doing a functional hemispherectomy. He's now 12 years old. He walks. He's fairly disabled in his cognitive and motor capabilities. And this is what his scan looked like. A very substantial infarct here, involvement of the internal capsule gone, wiped out. Not much of the thalamus left, a little bit of the basal ganglia left here. So again, reiterating what Eugenio said, that you need that involvement of the deep gray. So again, pathological handedness or other signs of hemiparesis noted later must clue you in to a presumed perinatal stroke. How do the delayed presentations look for presumed perinatal ischemic stroke? These kids are more likely to present with seizures and non-motor delay because they have cortical lesions and not the deep gray lesions. So they might come in because they've infarcted part of their epileptogenic cortex. Acute perinatal factors will be found if you go back and look at the record. The babies who have periventricular venous infarction, that was that little white matter intensity I showed you a few slides ago that look like PVL. The delays to diagnosis in this group are much longer. They're more likely to have isolated motor findings because they have deep involvement. And some of these children, even when tested for thrombophilias like this group, tend not to have identifiable abnormalities. Adam Curtin looked at a number of vascular syndromes associated with PPIS and found that this situation here involving the proximal MCA was the most common, but you can see the different patterns of injury, and each one of these patterns are associated with different types of motor disabilities. But this was 35% for the proximal M1 segment of the MCA. How do we evaluate perinatal stroke in our unit? We always obtain with the MRI an MR angiogram and venogram to rule out venous thrombosis and arterial abnormalities. I can tell you, I think I've seen one abnormal MRA. We never find the clots in the arterial circuit lesions, but in the sinovenous thrombosis, we pretty much always find the clots. So it's definitely worth doing venograms. We do EEGs just to see how active the baby is, especially they might be having subclinical seizures. We only do echocardiograms if there's identifiable risks, if it looks arterial, and if they have PFOs. We do consider metabolic disorders like congenital disorders of glycosylation, organic acidurias, and lactic acidemias. So we measure these in the children. This is a disorder of the mother and the child. It's a maternal fetal unit condition. So both the mother and the child should be evaluated, but usually not in the acute situation, because the coagulopathy workup requires measuring certain proteins that must be done once the baby is stable outside the period where the thrombosis has occurred. So we look for all of these things. D-dimers seem to be important if there's a massive stroke, although we haven't found that to be an absolute biomarker. Genetic tests are easy to do in the period, and this is helpful for future pregnancies. It's easy to talk about management for stroke because it's basically give good care in the nursery, because we don't have any real recommendations. The Class 1 Level C recommendations from the American Heart Association pay close attention to vital signs and signs of increased intracranial pressure. You would do any of this anyway. And if babies have intracranial hemorrhage, you obviously would correct and look for factor deficiencies. We only use aspirin prophylactically if the perinatal arterial ischemic stroke is due to multiple risk factors, which include prothrombotic risks and complex congenital heart disease. The evidence for this is not as strong. It's Class 2B, Level C. And the same thing is true for supplemental folate and yearly monitoring of homocysteine, which we don't do very often. How does the rest of the world deal with this? If we look at antithrombotic stroke treatment in all neonates with either arterial ischemic stroke or sinovenous, so arterial ischemic stroke is the blue, and the sinovenous thrombosis is the taupe, and this aqua are both. And you can see clearly the majority of these children are not being treated anywhere across the globe. For non-neonates, the balance shifts. The children are much more likely to be treated, whether it's arterial or venous. These children will receive heparin, low molecular weight heparin, aspirin therapy. So what is the true incidence? We don't really know because it's the tip of the iceberg in the nursery, and we're actually dealing with many more strokes that occur in the perinatal period but don't present until later. From data that has been collected around the world, we're roughly in the 1 to 2,000 per term birth. And in Estonia, there was a lovely study that went down to 32 weeks gestational age, and they had an incidence of 1 in 1,578 live births. When Heather Fullerton looked at ischemic stroke incidence in all of childhood, again, perinatal was far in excess of adult disease. And that's so profound and yet unrecognized, because if you go and ask any of your adult colleagues who has a stroke, they will talk to you about elderly people who have stroke, and never once consider that the neonates actually have a higher incidence of ischemic stroke. Yvonne Wu looked at a population in a healthcare maintenance organization to look for risk factors in the mother, because remember, this is a mother-baby problem, not just a baby problem. And any history of infertility raised the odds to 7.5. Preeclampsia was a risk, premature rupture of membranes greater than 24 hours, and chorioamnionitis. And actually, the risk of stroke increased as the number of risk factors increased. So if the mom had a history of infertility and choreo, a little bit more. If there was rupture of membranes, more, so that the prevalence rose to quite high by the end. And in the International Pediatric Stroke Study, the risk factors for ischemic stroke in the neonates, again in blue, most of them, half of them, no identifiable risk factors, some with cardiac, and then we move to systemic chronic and systemic acute disease. And note here that despite all our looking for thrombophilias, prothrombotic disorders are not that high, or are not that easily identifiable as a risk factor. And the same thing is true for synovenous thrombosis in the neonatal population, again in blue, about a third with no risk, some with cardiac disease. And then again, when we're looking, we're seeing acute symptomatic disease being the highest category. So those very sick babies, term babies, are at highest risk for venous thrombosis. And we have to keep that in our minds when we're looking at these babies. And again, number of risk factors for the ischemic stroke, many with none, just like I said. And then the population overall had relatively few risk factors, 1 or 2, but not greater in all of the neonates screened. But for synovenous thrombosis, again, about a third with no risk factors, and then kind of an even spread, but actually decreasing risk factors as the numbers increased here. So the way we think about it is as a maternal fetal unit problem. So we think about maternal and placental disorders, especially choreo. Despite our $1 million wasted on thrombophilic workups, we still tend to look for them because there is some data, especially Ulrike Nowak-Gottel's data, suggesting that we should continue to look because some of these need to be treated. Metabolic disorders, especially hyperhomocystinemia, which will come out on your organic acid screen. MELAS is mitochondrial encephalopathy, lactic acidosis, and stroke. This is a mitochondrial disorder rarely presenting in the newborn period, as is this X-linked disease. And the neurocutaneous disorders like neurofibromatosis, tuberous sclerosis, should also be considered. So make sure you include the skin examination as part of your evaluation. Congenital heart disease, infection, and trauma are always on the list and raise our index of suspicion. We did a risk factors study, and let me tell you just briefly what we did. In the US, every baby on day 4 of life gets a little heel stick. That blood is put on a filter paper, sent to the state, and a number of diseases are screened, and it's reported back to the university or the hospital of birth. The state actually stored all these blood samples, so we were actually able to go back and collect them, take those filter papers and run them in both immunoassays and genetic assays to look for polymorphisms in genes that you would think might be attributable to stroke. Thrombosis, thrombolysis, nitric oxide, cytokines, cell adhesion molecules. We had 347 controls and 59 newborns with stroke, so again, a small population. We looked at 31 polymorphisms, and no surprise, there was no difference population to patient. That doesn't mean there aren't genetic diseases, and I just told you about hyperhomocystinemia, about congenital disorders of glycosylation. And here is a family pedigree with a maternal mutation in MTHFR gene. All of these babies here were born with multicystic encephalomalacia. When these babies presented, they had clinical signs indistinguishable from hypoxic ischemic encephalopathy. So again, get the MRI for diagnosis as well as prognosis. None of the mothers received multivitamin supplements, and possibly if they had, some of these infarcts could have been avoided. Another very important gene that was genetic disorder first discovered by Doug Gould and reported in Science in both mice and men are disorders in COL4A1. It's a procollagen. These mutations cause perinatal cerebral hemorrhage and porencephaly. Linda DeVries published a beautiful paper in the Annals of Neurology describing 2 siblings who presented with perinatal hemorrhage and big holes in the brain. And I say again, another reason to get this scan, and if you see this, you should probably test for COL4A. This is a disease that is inherited and goes on for generations. It turned out that the mother actually got scanned and had lesions, and the grandfather died early and had a hemorrhagic stroke. So this was handed down for 3 generations until Linda DeVries came and made all the diagnoses. So stroke in the neonate is really a compilation and an overlap of a number of risk factors, including environmental factors that, with infection being most high, genetic factors like thrombophilias and cardiac disease, and maternal factors like infertility and preeclampsia. And you can see that these overlap is just going to increase, all of these factors can work together to cause thromboembolic stroke in the baby. What about mortality? The good news here is that it is not that high, and this is US mortality rate reported out a while ago, so 5 per 100,000 for infants, 2 per 100,000 perinatal, and about 4 per 100,000 live births per year. And then Heather Fullerton looked at this across 2 decades, and in-hospital mortality rate for stroke was roughly 10%. And when she plotted it out by age and stroke type, so here black is ischemic, hatched is subarachnoid hemorrhage, and purple here is intracerebral hemorrhage. You can see again the bulk of the infants who have, first of all, have the disease in the under 1 year, representing probably neonates. She couldn't get that from the hospital discharge data set that she used, actually time of onset. But you can see most of it is happening here. with mortality highest in the newborn period or in the first year of life. What about outcomes? We heard from Dr. Mercuri that it's not all bad news, but there are mixed data on this, and this is a compilation of data from over 40 reports compiled by Karen Nelson and John Lynch over a decade ago, and I'll show you more recent data. And when you combined everything, motor and cognitive, the scales were tipped toward abnormal outcome, with 40% being normal and 3% of the children who survived the neonatal period dying later on. When Yvonne Wu looked at that Kaiser database, she, let me get rid of that arrow. She separated it out based on babies who were presented acutely and babies that presented delayed. Now this is skewed, right? Because if the baby presents in a delayed fashion, the baby's going to have a lesion. So of course, all of those babies had cerebral palsy. That's how they came to medical attention. Whereas the acute presentations, much lower numbers, 30%, 37% for epilepsy, some language delay, and something we always forget about, the behavioral abnormalities associated with brain lesions. These are can be quite substantial and debilitating both for the child and for the family. This is work from Eugenio and Danny Ricci, who's maybe still here. And this is what Eugenio was referring to you before. They looked at 31 children who had strokes in the middle cerebral artery territory. 28 of the 31 were assessed at early school age. 78% had normal IQ. This is great news and reflects the fact that if you don't have involvement of those deep gray nuclei, you might have a better chance of having a good outcome. They did not see any consistent association between IQ, the side at which the lesion occurred, or how big the lesion was. And actually, the bad news, which is held up in other studies by Doris Trauner from San Diego, cognitive association was with seizures and hemiparesis. So if the children with stroke went on to develop epilepsy, they had a higher chance of abnormal cognitive outcomes, which speaks to Roberta's point about whether seizures themselves are actually causing the injury. And this is Doris Trauner's data, Ballantyne and others, that was published about 3 years ago now in Brain. They had 29 children with arterial ischemic stroke occurring in the perinatal period, 24 controls. They looked at IQ, academic skills, language function. They found no evidence of decline in function over time, which suggests that maybe the babies are actually exhibiting plasticity. That's the good news. But that plasticity was profoundly affected if the babies had seizures. So epilepsy was negatively associated with good outcome and plasticity of the brain. Meredith Galam also looked at the risk of epilepsy and could not identify any real predictors in this group. She looked at 64 children with arterial ischemic stroke in the newborn period. 75% actually presented with seizures. She followed 61 with a median follow-up of 43 months. 67% had or developed epilepsy, but 54% were seizure-free at the time of follow-up, and only 8% developed infantile spasms like the case that I showed you. Small group numbers, but it makes us think that we have to think about this. The infarct in these children was not always done by MRI. It was done on the basis of head ultrasound, and records were done by questionnaires. So Yvonne Wu also looked at radiologic predictors of cerebral palsy in that cohort that I've been showing you of these babies from the Health Maintenance Organization. And she saw a very low risk ratio or modest risk ratios for everything, including size, whether it was in the speech area, basal ganglia, or internal capsule. And the babies with these lesions, as Eugenio said, might have higher risk for cerebral palsy. From the International Pediatric Stroke Study, when we look at neurologic status at discharge for ischemic stroke, again, the neonates are in blue here. Very few die, only a third with deficit, and about half of them being normal at discharge. Some of them were lost to follow-up. So we can be very positive with the parents when we have identified neonatal stroke. This is for venous thrombosis. Again, even better numbers for the neonates with venous thrombosis, with 50% of them being normal, although a higher mortality reflecting babies who have very severe acute systemic disease that complicated their venous thromboses. These are data that aren't published yet, that we've submitted to one journal that rejected it, and and is now being submitted again. It's a purely descriptive study of symptomatic neonatal arterial ischemic stroke. So these aren't the presumed strokes. These are just the babies that you guys would recognize in the nursery. And this is what we found. The predictors of infarct characteristics. Multiple infarcts were seen with a very high odds ratio in babies who had a significant distress at birth and required resuscitation, including intubation. Maternal hypertension and acute neonatal systemic illness also tended to be risk factors, but resuscitation was definitely highest up there for multiple infarcts. Hemorrhagic infarct was predicted more by acute systemic illness, but sepsis, acidosis, and back to bilateral lesions also predicted hemorrhagic infarct. That is, the infarct starts out ischemic, but the baby goes on to bleed because of systemic illness. If we look at neurologic deficit at discharge and try to find predictors on a univariate analysis, vaginal delivery and urgent C-section. Presentation, noting a hemiparesis, noting tone reflex or any focal deficit, including seizures in the nursery. Newborn risk factors, underlying disease, prothrombotic state without actual thrombophilia, vasculopathy, fever. And left-sided, again, tended to be less common to go on to have neurological deficits at discharge for some reason. But the take-home on this is that these babies aren't all well, because when you look here, these are babies not coming from the newborn nursery. These are the well nursery. These are babies who are absolutely sick, requiring your attention right from the beginning. So what about the difference between ischemic and venous thrombosis? If we look at risk factors and stroke type and focus on some of the, so blue in this case is the arterial ischemic, and the tan is venous thrombosis. Cardiac, again, being biggest here for ischemic. And for venous, we're looking at systemic disease. These are, we excluded 31 patients who had both AIS and sinovenous thrombosis. The antithrombotic stroke treatment in the neonates, again, looking across the world at arterial ischemic stroke and sinovenous thrombosis, again, to drive this home. Most of these children, essentially 80% of the children with ischemic stroke, are not being treated. Whereas about half of the babies with venous thrombosis are being treated, and mostly in the situation where people are documenting progression of clot. So if the clot is progressing, then low molecular weight heparin, fractionated heparin will be used. And this differs from the non-neonates where most of them are being treated. And I showed you this data before. Here's the best news I can give you. It doesn't happen again, except in cases of underlying metabolic disease, genetic disease, or heart disease. So children with neonatal stroke have a less than 1% chance compared to children who have a 25 to 30% chance. This is great news that we can share with our parents. I think I'm going to finish it off here and leave the rest of the information about potential therapies to tomorrow. So thank you for your attention. Do you want to wait for questions then? Keep going? Now? Okay, questions from anybody? Eugenio.
Two questions. Well, actually, I remember one now. We don't use the CDG screening as a screening. How often do you find CDG cases in patients with stroke?
We haven't found one yet. But I know that there have been reports of venous thrombosis with CDG.
Okay,
so we do.
Not arterial.
Not arterial, venous thrombosis.
The second question, well, more than a question, was a comment. We have two cases with West syndrome and early onset hemiplegia, and in both cases the lesion was an antenatal lesion because in both on the very early neonatal ultrasound there were already clear sign of Wallerian degeneration on the conventional scan, not on the fusion. There was already a clear asymmetry, so we don't know when to date the lesion. So in our huge experience with two cases, we have seen only these associations with very early onset of hemiplegia. These children at 3 months already had a flex arm and clear sign of hemiplegia that we usually don't see very often in the perinatal ones.
Right.
And they both developed West syndrome.
Right.
I was wondering whether you have more information on the timing of the lesion in your case with early hemiplegia and West syndrome.
I don't have exact information because this baby presented to us late, but when I went back and reviewed the records, this baby had a very difficult delivery. There was an adrenal hemorrhage. The baby was ruled out for sepsis, had DIC, so was very, very sick in the neonatal period. This may have occurred prior to birth, but we don't know. There's questions back there.
Yes, I recently read something about therapy with low molecular weight heparin. I was wondering what you think about it.
We are very cautious for ischemic stroke in regards to heparinization of those babies, and we don't do it unless we actually have a positive bubble study and we think there are emboli coming from the heart, in which case we will. For venous thrombosis, it's a different story. If we see a thrombosis, we will image again. If we see progression of the clot, we will then administer low molecular weight heparin. But I can tell you this is not standardized anywhere. In fact, there will be a trial for anticoagulation in venous thrombosis that's going to be run out of the IPSS study, and hopefully we'll get more information. It seems to be safe so far, but it's not uniformly accepted or used.
What do you believe is the role of hyperthermia in those children?
I don't know, because we just have limited experience. But I can tell you we just have a paper that's in press right now in Journal of Child Neurology Mary J. Harbert, put together our data of all our cooled babies, looked at the babies who had stroke, and there were, I think, 9 babies compared to the 60 some odd babies with hypothermia HIE. The babies with stroke who were cooled, had no seizures. Whether that's real or it's spurious, just because we ended up cooling babies who were encephalopathic and weren't going to seize anyway, I don't know. But I think it's hopeful. I think we're only going to get that data as we combine all of these studies from all the different centers. Eugenio.
Well, one of the problems with this cohort is that very often you find the infarction, very often you find the infarction after 72 hours, because very often the first clinical signs is seizures between 48 and 72 hours, and by the time you have an ultrasound and you think you are already on the 4th day probably. Would
Right.
it be sensible to cool them after 4 days?
No.
No. So
I don't think so. I don't know. I just don't. You know, the adults have ongoing trials for hypothermic in hospital and out of hospital cardiac arrest in adults are very encouraging. The trials for hypothermia for in hospital cardiac arrest and out of hospital cardiac arrest in children are ongoing, but they are excluding neonates in those trials. These are US, Canada studies that are ongoing right now. So I think it's going to be a while before we even can attempt to answer that question and maybe get some data from what we're doing anyway. Alan.
Since we're mostly neonatologists, there's a couple of things that are happening in the community, and I'm curious if you think any of this will impact stroke. One is that in many countries, as you mentioned, there's a whole lot of C-sections going on. Many of these are occurring in these late preterm infants.
Late preterm or post-mature?
Well, we're avoiding post-maturity, and
Yeah.
we're
So
causing
you meant late preterm
deliveries.
Oh.
In fact, the data from the March of Dimes are, for the United States, that the mean age of delivery of the whole delivery population is shifted 1 week earlier because of the occurrence of C-sections and induced labor.
So below 36 weeks or below 40?
Below 37 weeks.
Okay.
The 35, 36, 37 week
Okay.
babies. And we know that there's a lot of good data developing now that the neurodevelopmental outcome isn't as good if you're born at 35 than at 36 than at 37 weeks. And you're really best if you're born at 38 or 39 weeks. That's when you're term.
I would put my hand up on that because I don't believe those data. I think the best time to be born is probably 35 to 38 weeks. So I don't know. When you look at the data for outcome, it's not till you get way down into the 20s that you see an association of age with outcome.
Well, there's actually
There are
population-
intervening
there's
factors.
population-
I just looked at this
Yeah.
data,
Well,
so I would
there are
argue
clearly
with that.
reasons why these kids are being born before 37 weeks.
Mhm.
But one of the major things is inadvertent C-sections.
But some of them aren't inadvertent, right?
Yeah, but a
And
whole lot of
maybe
them are.
non-urgent C-sections and the avoidance of, I will not advocate for C-sections, but I can tell you I have a friend in Italy, in the northern part of Italy, in a hospital that won't be named in Milan, where they do C-sections because mom wants a C-section and she's tired of being pregnant. They have a huge C-section rate. He could not enroll in some of these Euro trials because they never see HIE. Now, of course, he says there's a link between HIE and, that there's a negative association between elective C-section and HIE, which I think remains to be proven. But it is provocative. Does make you wonder, why doesn't he ever see an E? They're not ignoring it. He's a smart man. So.
But they're competing outcomes as well. I mean, it's clear that our neonatal units are full of these kids, and some of them have severe lung disease inadvertently. And in fact, in in the ELSO registry for pulmonary hypertension and ECMO, there's overrepresentation of these C-sections.
Coming from late?
Yes.
Or-
Yes.
Yeah. Because
So-
certainly post-maturity is associated
Well,
with
post-maturity is a
persistent.
problem, but that's
Yeah.
basically disappeared. And there are units in Argentina.
Not entirely. How many people see in their nurseries post-mature babies?
Occasionally.
I think it depends on what's
Yeah.
the access to care,
Yeah.
you know?
But there are large swaths of South America where in the private sector the section rate is 90%.
Hmm.
So this is an issue. And so what I was getting at, ultimately,
Yeah.
my question, is I think that we have large differences in intravascular volume in our babies. C-section babies, we know, work done at UCSF years and years ago, tend to have lower blood volumes. Term babies who are born vaginally have higher blood volumes. There's a new interest in actually delaying cord clamping, which will generate even higher blood volumes.
Yeah.
And I'm curious what your thoughts are about how that might drive stroke as an outcome, and then we can argue about late preterm babies over at Warren
Yeah,
later
well,
on.
I'll just say briefly, I don't know, but I think the delayed cord clamping is very scary to me, and I think the proof will be in the pudding when we start seeing increases in abnormalities.
Of course, if you take it from an evolutionary point of view, when we were born in caves, they always had late cord clamping, right?
Yeah, but we could probably get around on all fours back then too, so spastic quad wasn't so bad. Eugenio, do you have, or Roberta, any comments about this outcome associated with, worse outcome in a 35-weeker?
We have followed some 34, 35, 36 and 37, and the only difference we can notice is really in the 34 or early 35, but there are not huge differences. With the others, we couldn't notice major differences. We have been following quite a large cohort recently, and done neurological and cognitive and all the vision stuff that you will see this afternoon, and we couldn't notice too many differences.
And Roberta?
Actually, there is a paper that has been published on GMA in 2004 from a Canadian group of gynecologists and neonatologists looking at the Canadian Register of Strokes. And actually, they found over 212,000 babies, a percentage of stroke that is about 14 per 1,000, so pretty high. And they found this association with IVF and with C-section and with somehow bird asphyxia. And then they commented and they said maybe bird asphyxia was a wrong diagnosis, so they were not actually asphyxiated.
Right.
They said maybe IVF has something to do with placenta problem that is from the mother. And they suggest, they make the hypothesis that maybe C-section could activate thrombotic factor in the mother and then somehow facilitate a thrombus in the baby. So this is what they found.
Donna, what's your view of hypothermia per se as a cause of neonatal stroke?
Hypothermia as a cause?
Yeah.
I don't have a view on that, actually. I have not. I don't know. I don't think, in all of the studies, the adverse events were so minor, and never were we seeing stroke associated with hypothermia. And when you look at the cardiac populations where profound hypothermia is performed during surgery, the strokes that occur in that population are actually occurring prior to surgery, not during surgery.
Yeah, I was just listening to your, in your study when you're looking at when you were cooling the group and you found out that 9 of them were actually had stroke rather than, whether MRI was done before you have found out that these babies had stroke, or was it done before they've been cooled?
No,
before
the
these
MRIs are all done afterward.
afterwards.
Yeah, so we do MRI on day 4 to 5 usually of life, so after the cooling.
I think that there was some concern at the beginning when they started the Toby that I think Marianne Torrensen at the very beginning mentioned there were some hemorrhagic components associated with cooling, but this was just at the very beginning, and then they repeated the experiments and they couldn't
Couldn't
confirm
find it, and
yeah.
some of the
I think
piglet
this was the
data.
only thing I heard about possible
Right,
hemorrhagic
and we were
lesions,
worried
so-
about cardiac arrhythmias. Yeah, yeah,
It was a fear.
yeah.
would change coagulation.
But there was never an adverse event in all of the studies that related to
Once they
that.
started properly
Yeah.
the study, they couldn't find it. Yeah.
But don't you think that when you cool these babies, there is some sort of anti-platelets effect following hypothermia?
I have Mr. Cool here, so
No. What's the
I think actually what we do, we check for hemorrhage, so we do a ultrasound, and if they have an hemorrhage, they should not be cooled, just because they can get worse or they are more at risk. If they have a pulmonary hemorrhage, we discuss about rewarming them, but not as because the hypothermia can cause hemorrhage, but because if they have an hemorrhage, they can be worsened by hypothermia. But
This,
I never heard
this is
hemorrhage
moderate,
due to-
very moderate hypothermia. We're talking 33.5 degrees. And we have a huge experience with deep hypothermia for the cardiac babies that don't push us in the direction of feeling. Those babies are anticoagulated by virtue of having to be for the surgeries, and still we don't see these risks. So I think I'm not so. George?
Yeah, I want to point out that there is a difficulty in assessing the coagulation status of a cooled baby because all tests are done at normal body temperature, and this does not really relate to the coagulation status at 2 or 3 degrees lower. That's one thing. The same is true for the pH and SFA status. You know, you would have to correct for temperatures. So I think this is an inherent problem in assessing conditions which might lead to some problem like hemorrhage.
It's a question.
You said before that you have been doing MR angio for all these babies, arterial and venous. Do you have maybe some examples and also practical? How is it done? Does it take much longer than normal MR?
It adds, the MRA is a time of flight testing without contrast. Same with the venogram. So you're adding probably another 12 minutes to the study. I can show you some pictures later, but I have to go look for them on my computer.
Don, I'm curious, there's two pathways to prematurity as the dominant pathways that people think about. One is via vascular problems, which relate to the maternal, the fetus, the preeclamptic, and that whole series of abnormalities, growth restriction. And the other is infection. And basically, your data would suggest that both of those are pro-stroke in the sense of either the infection component or the preeclampsia. And that makes sense, I suppose. What's the relative rate of stroke in preterms versus
So
terms?
according to the data that I showed you from Manon Benders and Linda DeVries group, they looked at 32 weeks and above, I think. 32 weeks and below. I'm sorry, 26 to 32 weeks, and they had 1 in 7,000 live births.
Because you'd think that those severe preterms who have the severe effects of the vascular problems, the preeclampsia, the growth restriction and whatnot, might be at real risk, for example, but that doesn't seem to be the case. Either that or we misidentify their stroke as a big IVH and blow it off as that or something.
Yeah, that's possible, but I think it's overshadowed by the fact that in those babies who are severely compromised, especially with bad lung disease and infection, you're seeing a lot of white matter injury on the MRI that could be focal stroke. That could be small vessel infarcts. We don't have the data and the pathology to go back because the babies don't usually die.